Thank you for joining us for our tertiary prevention project on sexually transmitted infections, specifically HIV. This is being presented by Jasmine Batchelor, Johanne Fabre, Carlos Quijada, Rebekah Israel, Tracy Smith, and Elizabeth Winings. I'd like to start this presentation by discussing the epidemiology of HIV within the United States. The most recent research is for the years 2010 and 2011. During those years, there were more than 1.2 million people living with this disease at that time. There are significant negative health outcomes associated with HIV, such as skin infections, periodontal disease, infertility, a suppressed immune system that can progress to full-blown AIDS, and ultimately death. The symptoms of HIV are not explicit, and it is common for individuals to be reluctant to seek health care. The health outcome effects range from mild impairments to serious health consequences, as we will further discuss these in our presentation. The subgroup most affected by HIV is males, specifically men who have sex with men. In 2010, 76% of individuals living with HIV were male. 69% of these men were gay, bisexual, or having sex with other men. Over 10,000 youth were diagnosed with HIV in 2011. More than two-thirds of HIV diagnoses for those ages 13 to 19 were also male. Tracy is going to further discuss why are we targeting this population.
So our targeted group is Black males 13 to 25 living in the U.S. at or below the poverty level who have already tested positive for HIV. So why are we targeting this group? Approximately half of all new HIV infections occur in young people less than 25, which accounted for an estimated 26% of all new infections. So according to the Centers for Disease Control and Prevention, in 2010, young gay and bisexual men accounted for an estimated 72% of all new HIV infections in the United States among youth. This was an increase of 22% from 2008. So most young men who have HIV acquired it through male-to-male sexual contact. Between 2006 and 2009, HIV/AIDS cases among young men ages 13 to 24 who have sex with men increased across all ethnic groups, with young African-American Black men mostly affected. So as you can see from the statistics, targeting this group would be beneficial so we can educate this group on ways on preventing new HIV cases and managing the disease. So some of the reasons why we have such a high rate among males 13 to 25 is because of low rates of condom use, low rates of testing, and large percentage of gay and bisexual men living with HIV. Many people with HIV do not receive ongoing treatment, social and economic inequalities. Another reason is there's a need for a tailored prevention approach for our diverse population, such as gay, bisexual, and MSM communities. So these are just a few of the prevention challenges that we have, but our plans for learning more about this group is through community-level intervention. So collaborating with community, state, health departments on current research data for our targeted communities. Also developing profiles which would help us really pinpoint the reasons for the high HIV rate amongst our focus group in that community. One-on-one group educational and counseling programs allows for privacy and also allows us to capture information directly from our targeted group, which could provide a lot more data for our research. So the next thing we'll be discussing is the social ecological approach.
This is Carlos Quijada. I'm going to speak about the social ecological approach. Theoretical concepts such as Bronfenbrenner's ecological framework increase knowledge on the link between the health of HIV adolescents and their environment. Using a social ecological framework increases the understanding of individual, community, and structural elements of health. According to research, the overall health experience and quality of life of adolescents and young adults living with HIV depends on the interaction between these factors. These factors include the microsystem, or individual, mesosystem, interpersonal, exosystem, social, and the macrosystem, or broad. It is interesting to note that there are bidirectional influences between these systems, which imply that relationships have impact in two directions, both away from the individual and towards the individual. When the relation between different microsystems is compatible, development progresses smoothly, and in this case, high quality of life while living with HIV. In the microsystem, the stressors within the microsystems identified by the youth include factors that they interact with directly. Some of the themes that emerge within the system include the family, sexual partners, significant others, peers, healthcare settings, work and school, and the HIV disease itself, since many youth experience the demands and stressors of the illness directly. According to research published by Dr. Hosek in a Journal of HIV and AIDS Prevention in Children and Youth in 2013, some of the stressors related to family, as reported by adolescent and young adults living with HIV, include several sub-themes related to the youth interaction with family, which include the disclosure of the disease, misinformation of the disease, and rejection by family members. There are also stressors related to sexual partners and significant others. Young adults and adolescents living with HIV often express a lack of desire for being involved in a sexual relationship. In this microsystem, we also find stressors related to peer, school, and work. For instance, with peers, friends treat HIV-infected adolescents differently and spend less time with them. In school, often adolescents will miss classes due to their medical appointments. And similarly at work, the adolescent experiences physical and emotional ailments that make it difficult for them to function at work. Finally, in the microsystem, we observe the stressors related to healthcare settings. According to data from the CDC, the majority of HIV adolescents did not have a routine healthcare previous to the diagnosis. They also face repeated disclosure within the healthcare system, since HIV youth have to continually reveal their status to various health facility personnel.
Moving on to the mesosystem. Mesosystems are formed when there is interaction between two or more microsystems. Mesosystemic themes emerge from HIV youth in the areas of school and peer and family partners. For instance, stressors related to school and peer interaction is when many youth experience stress within the school system, when their peers make negative or judgmental comments about HIV or people living with HIV. When it comes to stressors related to family and partner interaction, the stress caused to adolescents by family members blaming the participant's sexual partner for the infection. It is interesting to note that most mesosystems for other chronic diseases look at the interaction between caregivers and hospitals. However, most of the HIV youth are directly responsible for the disease management and do not have the traditional caregivers that can be present with other chronic childhood illnesses. Moving on to the exosystem, exosystems describe environments in which the individual is not directly involved. Other people and places that the youth may not interact with often, but that still impact them anyways. Exosystemic themes emerge in the areas of parental workplace and local media. As adolescent tries to cope with their own HIV status, they are further burdened by the stress that the parents face at the workplace to ensure their healthcare coverage and that they're taken care of. Stressors related to local media identify the influence of the media as a major source of stress when they feel that television in particular portrays HIV in a negative light and is often confused or synonymous with AIDS. Moving on to the macrosystem, it's a system where it generally consists of larger societal structures, including social, cultural, and political values that impact society as a whole. For Black males in particular, the high level of stigma attached to HIV at the societal level, as well as the violation of privacy and confidentiality laws, create a tremendous amount of individual stress. Violation of privacy and confidentiality laws is a major concern voiced by all HIV youth. Several research has shown fear of laboratory technicians, school nurses, or other hospital staff revealing their HIV status to other people without their adolescent's authorization. Finally, there are stressors related to cultural values and access to healthcare. Funding for quality healthcare centers for children and adolescents can be a source of stress for newly diagnosed HIV youth. In certain regions, there are very few doctors experienced with the treatment. Additionally, the lack of appropriate funding for HIV services and centers can be very stressful for HIV youth. Perhaps one of the most widely publicized macro-level determinants of adolescent HIV quality of life is how social and cultural norms manifest as stigma and discrimination. Jasmine will be speaking further about this topic.
Thank you, Carlos. I'm going to talk about the stigmas. Here you see that stigma based on many different researches show that individual stigmas show that after positive testing, most individuals feel ashamed of having this HIV virus and start to isolate themselves. You can also see under community stigmas, many researchers have also shown that people within the community believe that HIV is a gay disease or they believe that those get infected by risky behaviors only. So like drug abuse or unprotected sex. Next, they're going to explain the intervention designs.
Thank you, Jasmine. I'm Johanne Fabre, and I will quickly go over the details on our project, iTEAM. So what is iTEAM? iTEAM is an intervention which emphasizes on disease management, optimization of quality of life, and prevention of opportunistic infections. The I stands for initiative, the T for treatment, the E for education, the A for adherence, and M for management. The two levels that we target from the socio-ecological model are the individual and the community. At the individual level, the objectives that we have are to limit the possibility of other infections by testing for other STDs, such as chlamydia, gonorrhea, herpes, and trichomoniasis. And we also want to educate on how to deal with feelings of shame and social stigma and help increase rates of status disclosure. And lastly, we also want to recognize that other illicit behaviors might need to be addressed, such as substance abuse, impairing judgment, or sharing needles that can put at risk negative users. At the community level now, we have on-site classes, we have internet forums for safe sex education. We also have discussion to help participants coping with the diagnosis and readjusting to daily routines, away from shame and social stigma. The iTEAM includes 3 components. The first one, we have the peer navigation that provides the participant the social support they need by helping them identifying and overcoming barriers that could interfere with the treatment. The second one, it consists into weekly workshops focusing on health maintenance. The participants are educated about HIV treatment, prevention, and the possibility of catching other infections if they fail to have responsible and safe sex behaviors. The treatment plan is also discussed in detail along with the side effects of the drug that they're taking. Example, we have the ART that can have the changes in the physical appearance. And the last component of the iTEAM program, we also have the anti-stigma campaign. When they have the knowledge about the HIV, the participants know that they can lead a normal life and they don't feel ostracized in the community. They know they can keep focusing on achieving their goals that they had prior to the HIV diagnosis. Now, Rebekah will expand on the nature of the intervention.
Thanks, Joanne. So now that we've talked a little bit about the design of the intervention, I'm going to go into a bit more details about how iTEAM is actually going to happen. So as Joanne mentioned, and again, this is Rebekah Israel speaking, we're focused on 3 main activities for this intervention: patient navigation, weekly treatment education workshops, and the anti-stigma social media campaign. So in order to explain how the components of iTEAM is going to work, I'm going to go over the planning process, the implementation process, and then talk a little bit about evaluation and sustainability. So for the planning process, we're going to start with conducting focus groups with the target population. So although we've done a lot of research on their needs, we know that young Black men living with HIV know best what they need from a program. So their input is going to be invaluable to the planning process. So we're going to use those focus groups to develop the curriculum and facilitators guide for the weekly workshops, and then help us decide what weekly topics we're going to discuss in those workshops again. Another main aspect of the planning will be the recruitment and registration of participants. So we developed this intervention to be implemented in community-based settings. So we're going to be recruiting at local AIDS service organizations and community-based organizations, and kind of using a snowballing method to get more people interested in applying to be participants. And so registration will include debriefing the participants to all of the iTEAM goals and pairing the participants with their peer navigators. Next, we'll have implementation. So the participants will go through the program for 12 weeks, and they'll be paired with patient navigators to ensure that they get to appointments on time, making sure that they have better communication with their doctors, and ensure that they understand the implications of having HIV and kind of learning how to manage their disease better. iTEAM participants will also attend weekly group workshops where they'll learn about a particular HIV-related topic, and that will include treatment as prevention, prevention with positive, going over the ARV drug classes, talking about STI testing, disclosure. All these types of topics are going to be included in those weekly workshops. And then also they're going to be used to discuss more personal issues related to living with HIV, as Joanne talked about earlier. And so finally, the anti-stigma campaign, during week number 6, the participants as a group are going to be working on an anti-stigma campaign to educate the public on HIV. And so it can take the form of an educational video, a Twitter hashtag, or some type of fact sheet. But the point of it is that it's going to give the real facts about HIV and kind of try to reduce the stigma surrounding HIV in their communities. And so at the end of the 6 weeks, which will be the summation of the program, each cohort or each group will publish their anti-stigma campaign. And so for the evaluation phase of iTEAM, the participants will be given pre- and post-tests to assess their health literacy. And they'll also be, we're going to interview them at 6 months and 12 months after graduation. And the point of that is to kind of really see how iTEAM affected their adherence to ART, improved their quality of life, kept them retained in care, better improved their communication with their doctors. We really want to kind of get those, details about how iTEAM, affected their ability to live with HIV better. And then after graduation, in order to sustain the program, we're going to give participants the ability to become workshop facilitators. And so they're going to do that in pairs if they're interested. And then we're also going to give them the opportunity to become patient navigators. And so we also realize that, some of the people who graduate from the program after 12 months, after 3 months, are probably going to need patient navigators for a longer period of time. And we're also going to give them the opportunity to do that once they graduate as well. And then finally, we're going to publish these anti-stigma campaigns, and this is something that's going to be able to be used over and over again to educate their families and their friends and their communities, so that everyone else is not, so everyone else that they're around that they have to live with and interact with are given the proper information about HIV and how it's contracted and how it's prevented and things like that. And so now we're going to have Jasmine again come and talk about the model.
Thank you. I have created a model under the holistic approach to better understand our intervention. We use 4 different variables, which is self-efficiency, health literacy, stigma, and ART, which is the antiretroviral therapy. First, we're going to look at physical. We want our individuals or peers to feel self-efficient and to better understand how to manage their disease by using the patient navigation. This way, we can help them to know their symptoms of the disease and the treatment by going to appointments and talking to their doctors. We also want to educate them on the optimal treatments. So ART, which is the antiretroviral therapy, it is a therapy which uses a mix of 3 antiretroviral drugs that suppress the HIV virus and stop the progress of the virus. Research shows that there has been a reduction in deaths and suffering in the early stages of this virus. And this is also a form of harm reduction. Next, we'll go to the physiological. And here we will focus on health literacy and health and HIV literacy. We want the individuals to go to the workshops and weekly discussions like Rebekah talked about. And we want them to adapt to the disease and understand the disease and know the terms and understand what the doctor is saying. we want to decrease the negative emotions and the negative thoughts that they might have. We want to decrease depression. So with the peer groups, we want our individuals to be in the same room with those who have the same disease so they can easily communicate and share information and hopefully cope with their disease. Next, we're going to go to spiritual, where we look again at self-efficiency and art. We will do the follow-ups, like again, Rebekah has talked about before, and we want to do assessments and reviews, making sure that these individuals are in good spirits. They make sure that they are following their plans that we discussed. We also want to advance care. We want to advocate for art. And we also want to advocate for any different type of therapy that we might think will keep our individuals staying positive and healthy through this process. And last, we want to look at social, focusing on the isolation and the stigmas that I talked about earlier. And with that, we're going to do the anti-stigma campaigns that Rebekah did talk about before, so I won't go back into much detail. But we just want to take out the negative views out of the community and put in facts and show people, the actual facts and statistics of HIV and how one should be treated. And next, we're going to go on to the potential barriers.
About the potential barriers to implementing iTEAM. So of course, funding is always an issue, so that might be something that comes up, and we would ideally like to give the patient navigators and the workshop facilitators a stipend, and so of course that's going to be dependent on how much funding is given for the program. Another potential barrier is retention for the entire 12 weeks. We like to see the participants keep coming back for the whole 12 weeks because we think that it'll be beneficial and we wouldn't want them to miss any of the topics that are discussed. But people have lives, and we know that things happen and they may not be able to come for the entire 12 weeks, and so that's another issue that we have to deal with. Also, tracking progress. I talked about evaluation a little bit earlier, but there are some things that we might have difficulty tracking with this. Because, you think about the interviews, people may not want to necessarily give their personal information. And so, of course, we're only going to be taking responses from people who signed an informed consent. But that might not be everyone, so then we might not get the full view of how iTEAM actually impacted their lives. And then also thinking about the social media campaign, that's a little bit harder to evaluate. So we can evaluate quantitatively how many people are engaged with the social media campaign, like how many views or clicks or, hashtags. But qualitatively, to see how people are impacted by the campaign is a little bit more difficult to measure, and it takes a longer time to measure. So that's another issue that we're going to be dealing with implementation. And then also, finally, establishing who's going to be the workshop facilitators and the peer navigators. Like we talked about, it's going to be focus groups, but we do want to make sure that whoever we choose to be in these roles are really people who are, passionate and capable and competent in doing these roles, because it's going to be something that's significant in our participants' lives. And so these are some potential barriers, and there may be more, but these are the ones that kind of stick out to us in this program. So in summary, well, we know that young Black men are disproportionately affected by HIV. And so iTEAM seeks to reduce this impact by focusing on men who are currently living with HIV, and who are newly diagnosed, lost to care, inconsistent in care. And our hope is that iTEAM will reduce the barriers to adherence, increase HIV and health literacy, build self-efficacy to manage HIV, and optimize our quality of life. iTEAM will also empower participants to engage in the fight against HIV stigma in their community. Together, we believe that by achieving these goals, we will significantly improve the lives of young men living with HIV, and by that, we will also kind of improve the impact that HIV has on young Black men on a larger scale as well. So here are the references that we've used to develop this intervention. And I'm going to go through these very quickly, but we thank you for your time.
and we hope that you agree with us and that iTEAM would be an ideal intervention, tertiary intervention for HIV prevention.